Good afternoon, I suppose, everyone. So this session, this is going to be a really interesting session. We have Vivian Chua, Dr. Vivian Chua, and Associate Professor Tim Luckett talking to us today. They're both researchers, but quite at the opposite end of the spectrum. And I'll be really excited to hear from both of them. So Vivian is in Western Australia. She's a cell biologist and has a PhD in this field. She's been working in uveal melanoma for a decade and recently set up her own lab at the Edith Cowan University, which is no small feat and I'm sure incredibly daunting. And so it's fantastic to have her here. Then Tim Luckett is right at the other end, so not at the bench top. This is at the other end of research on quality of life and how we focus on patient-centered care. And so we're not just trying to improve outcomes, we also, in terms of clinical outcomes, we want our care to be what the patients actually want from us. So it'd be great to hear from them both. And I think we're starting with Vivian, who is here now. Thanks.
Okay. Hi, everyone. Thank you for the introduction and to the organizers for the opportunity to present our research. So before I begin, I'd like to draw your attention to a poll question that I set up on your screen to the right. It essentially asks you about how familiar are you with uveal melanoma progression. So if you can answer that quickly right now, that'll be great. And I will address that in the second slide of my presentation. So as the title of my presentation suggests, our research has been really interested in looking at the roles of BAP1 in uveal melanoma. The reason being that many of you probably would have already known, BAP1 mutations are present in about 30% of uveal melanoma cases, and these are frequently in metastasizing or metastatic uveal melanoma. These are inactivating mutations, meaning that they will lead to loss of BAP1 protein function or BAP1 protein expression, which would have an impact on function. BAP1 mutations are often associated with a poorer disease prognosis and an elevated risks of metastasis. However, the role of BAP1 loss in uveal melanoma progression are still very unclear. So as I mentioned in the poll question, I asked you whether you're familiar with how uveal melanoma progresses. If you answered very little or no, I hope that my presentation today with some of the new data that we have in preclinical models will be able to give you a little bit of an insight about what's happening with uveal melanoma progression. So we know that uveal melanoma spreads or metastasizes through the blood circulation, for example, here in the blood vessel. And it would arrive at a secondary metastatic site, and the most common being the liver. So we're very interested in addressing this question: why does BAP1 deficient uveal melanoma have a higher propensity to metastasize compared to BAP1 proficient uveal melanoma? And so it is very reasonable that we go on to look at BAP1 specific changes or alterations in a huge number of proteins, protein functions and protein levels in the cancer cells, and also what BAP1 does to cell characteristics. So it's been shown previously, not in the uveal melanoma space, that BAP1 functions as a deubiquitinating enzyme. So what this means is BAP1 has been shown to remove ubiquitin molecules, as you can see here, out of certain proteins that BAP1's been reported to bind to or interact with. And this can have an impact on the expression levels and functions of a huge number of genes within the cancer cell, and that have an impact further down on cell characteristics, for example, cell proliferation, which is how fast or how slow cells grow and divide. So about a decade ago, one of our collaborators in the United States, Bill Harbour, have shown that BAP1 knockdown through a molecular biology technique, which would decrease the levels of BAP1 in uveal melanoma cell lines, were shown to slow the proliferation of cells. And so this is quite a unique characteristic of BAP1 deficient uveal melanoma, and we were interested in pursuing this further. So our research aims were threefold. First of all, we wanted to address the what, which is to confirm whether this slow proliferation characteristic is observed in multiple BAP1 deficient UV melanoma models. Secondly, how? How is this slow proliferation come about in these cells? And so we wanted to determine mechanisms associated with slow proliferation. And then the why, which is the most exciting and interesting one, which is why are these cells slow proliferating? And would this be contributing towards the metastatic capabilities of BAP1 deficient uveal melanoma? And so, to address the what, we have these human-derived UV melanoma cell lines that has been used in multiple UV melanoma preclinical labs across the world. These are BAP1 wild type and BAP1 deficient cells that we have confirmed with a technique called Western blot, which essentially looks at protein positivity or negativity in these cells. In this case, BAP1, as you can see, it's positive in the BAP1 wild type cells, but not in BAP1 deficient cells. So what we did is we put these cells into an IncuSite live cell imager. It's a machine that takes pictures of cells at a high magnification. So for example, what we see are these images, for example. So this machine takes pictures of cells every 2 hours over time. And what we found was that BAP1 wild type cell lines, these ones at the top, were growing at a faster rate compared to BAP1 deficient cells. We also have other models. For example, here we genetically modified some of our BAP1 deficient cell lines. For example, here I'm showing MP65, which is BAP1 deficient, and we modify them to re-express the functional form of BAP1. So as you can see here, we confirm positive levels of BAP1 in this particular cell line. So then we used a different approach to look at cell proliferation. We put these cells into a 3D matrix called Matrigel. So we put them as single cells at day 0. And then we let the cells grow, let them proliferate and divide from a single cell into multiple cells, into this cluster of cells that we usually would see that resembles a tumor in humans. And so at day 4, we calculated the number of single cells and also clusters of cells. And what we found is that the BAP1 deficient cell line, MP65, as you can see in green, the majority of them at day 4 are still stuck at the single cell phase, and just a very little bit, just a very small proportion of them had divided from a single cell into multi-cell clusters. On the contrary, the BAP1 re-expressing cells, MP65 BAP1, we see a significant decrease in the number of single cells at day 4, and a lot of them had divided and grown into into clusters of cells. Some had 3 to 4 cells, and some had 4 to 8 cells. So we have confirmed that BAP1 deficient cells are slow proliferating. So then we wanted to address the how. And so we did this by performing a technique called reverse phase protein array, which is essentially looking at the levels of about 500 proteins within the cancer cells. And so we found these proteins, PS6, to be expressed at very high levels in BAP1 proficient cells. For example, as I mentioned in the previous slide, the BAP1 re-expressing MP65 cells, and also in the panel of BAP1 wild-type cells. So just to give you a little bit of a background on what PS6 is, for the scientists in the room, so PS6 is part of this elaborate molecular pathway that is mTORC1 and mTORC2. And PS6 has been linked with protein synthesis. So essentially, it recognizes amino acids, which are building blocks of proteins. And so they link these amino acids into complex long chains of amino acids that form proteins that are very important in normal cell proliferation and also cancer cell proliferation. So we then establish this link between low PS6 and slow proliferation through this experiment. So what we did is we again genetically modify the BAP1 deficient cell line MP65, which has low levels low levels of PS6. And we modify them to express this active form of S6K1, which we know would reintroduce PS6 into these cells. And so again, as we expect, with high PS6, the cells grow faster compared to the BAP1 deficient cell line, which is BAP1, which is MP65. So now to address the why, which is the interesting part. So we go back into what PS6 does. As I mentioned, it's involved in protein synthesis, which is something that really benefits cancer cells. And so you can imagine that if you take amino acids away from them, or if there is a low supply of amino acids, you would expect cell death with these cancer cells. And so in this case with BAP1 deficient uveal melanoma, we were wondering if they have programmed themselves to have a decreased PS6, potentially to avoid that cell death in case of a low amino acid condition. And so we were able to show that in this experiment where we put wild type BAP1 and BAP1 deficient cells in a condition that had low amino acids in the cultures. So as you can see in the BAP1 wild type cells, they're very happy, growing very well in regular condition with a lot of amino acids. But when you put them in a condition that had low to zero amino acids, for certain amino acids, you see a lot of death or not a lot of survival, as you can see with the low purple staining of viable cells. On the contrary, the BAP1 deficient cells, you see more purple staining, so there's more survival of the cells, even though they're in amino acid low condition. And this is just the quantitation that we did of this experiment that was repeated 3 times. So a lot of these findings were published recently at Science Signaling, and what we're able to show right now is that BAP1 deficient uveal melanoma cells undergo this mechanism that I did not go into today. But this mechanism leads to low PS6 levels in these cells, which leads to slow proliferation of BAP1 deficient uveal melanoma. But when you put these cells into an amino acid low condition, there is better survival with BAP1 deficient uveal melanoma compared to the rapidly proliferating BAP1 proficient cells. So in theory, what we think is happening, and this is something that we're trying to address, and this is something that we're trying to address in ongoing studies in the lab, is whether these BAP1 deficient cells are able to survive better under amino acid deprived conditions, for example, in the blood circulation. It's been shown that in the blood circulation, amino acid levels are lower compared to most tissue. And so this leads to higher possibilities of BAP1 deficient cells to arrive at the secondary metastatic site. And because these are slow growing cells, and so there is a potential that over time there's interaction between uveal melanoma cells and the liver cells in the liver microenvironment that reprograms these cells into the aggressive tumors that we see in patients. So some of the areas that we think could be therapeutically targetable are the mechanism that leads to low PS6, mechanisms that promote survival under amino acid starvation, and targeting this interaction between liver cells and uveal melanoma cells. So I'd like to end by acknowledging my current institute in Ifgao University. I'm part of the melanoma research group that looks at liquid biopsies technology for uveal and cutaneous melanoma. The Center for Precision Health that I'm part of. I'd also like to thank my current and past Mentors, current because I'm still talking to them very regularly, Professor Andrew Applin and Professor Takami Sato. And my collaborators mainly in the United States because I just moved back to Australia last year. And last but not least, the continuing, the funding bodies that are for their continuing support towards our research in uveal melanoma. Thank you very much.
The sunnier shores over here in Victoria, but nice to hear from you, Vivian. So the next we're going to hear from Tim Luckett, and then we'll have some questions and chat at the end. On you go, Tim. So Tim is part of Sequest and focuses on quality of life research. And his presentation should start shortly. Thanks.
Great. Thank you very much. And thank you for inviting me to talk today. I'm presenting on behalf of a multidisciplinary team that includes a few of us from the University of Technology, Sydney, but also 3 medical oncologists whose names you see there and may be familiar to you. So I don't need to tell this audience that immunotherapies and targeted therapies have improved survival for many people with metastatic cancers, but they have also increased prognostic uncertainty. And metastatic uveal melanoma is paradigmatic for our understanding of this uncertainty. Because first and foremost, it's a very rare cancer, but it has a very high chance of metastasizing after early treatment. It usually metastasizes to the liver, so it's relatively symptom-free until shortly before people die, which really brings those psychosocial concerns to the fore. And of course, as this audience will be aware, there were very few treatment options available until 2021 when we had the trial of dabentifusp in the New England Journal. That in itself, of course, as a treatment has huge uncertainty. Firstly, it's only available for people with a certain genetic variant. Some people mysteriously have a survival benefit even when there is no evidence from scans of a tumor response. And it's also variable in its availability in health systems internationally. So in other words, just how incredibly uncertain can you get? So this project really did try to explore people with MUM's experience and coping with uncertainty. And we're using it really as an exemplar to learn about ways we can support people with other metastatic cancer treatment contexts that are somewhat similar. We used a qualitative approach, so in-depth Zoom interviews. Because it's a rare cancer, we sampled internationally through peak bodies, but we also recruited through 2 Australian hospitals. And while we did code based on what people were telling us, we also applied Michelle's theoretical framework of uncertainty in illness, which you see depicted on the right-hand side of the screen, but we'll be going through when I report the results. So we ended up interviewing 17 people with MUN. As you can see, most of them were from Australia. About half of them were under 60 years old because it is a cancer that affects younger people. And in terms of survival, most of them were already doing very well in terms of the usual bell-shaped curve of survival. 94% of them had metastases to the liver, which we would expect. More than half of them had had dabentifusp, but also they'd experienced a range of other treatments. And because they were relatively symptom-free, nobody had been referred to palliative care really for lots of advanced care planning and that sort of thing. Okay, so I'm going to step you through each part of Michelle's uncertainty framework. And the first section of that highlighted in red is the stimuli frame, or factors that contribute to or reduce uncertainty for people. And first and foremost, it's the symptom patterns in disease. And yet with MUM, people spoke about the eerie absence of symptoms and the feeling of absolute normalcy that most of them were experienced. Like this Canadian man put it, he always jokes when people ask him how he feels, and he says he feels like he's telling them he doesn't have, he's got something that he doesn't have. And nearly all of our participants talked about that, their life carrying on perfectly normally. The regimen, though, of treatments was very different from the earlier treatments that people had received. And they often had friends and family who were familiar with treatments like chemotherapy. So they'd say, you know, well, how many rounds have you got to go? And of course, these people were on treatments forever until the treatment stopped working, essentially. And they would have to try something else. Many people experience anxiety, you know, when going for a scan, which of course are scheduled at routine times. So there was no uncertainty about when their scans were booked in, but there was huge uncertainty about the results of those scans. And most people felt incredibly anxious and stressed in between the lead up to those scans and then when they actually got their results through. Conversely, people were actually surprisingly reassured by the predictability of the side effects. Even though some of these were really extreme in terms of the rash and the itching, people were actually comforted by being told you may get this side effect and then it actually arriving right on cue. And of course, many people had been told by their oncologists that these was a sign that the treatment was probably working well for them. The next part of Michelle's framework is about structure providers, so factors influencing how people interpret their disease and treatment. And three attributes of people seem to be really interrelated and important with this regard. So how much they actually wanted to go information seeking, the degree of involvement they wanted in making decisions about their treatments, and the degree of trust that they had in their medical teams. And these were all very, very closely related. So in some people, they found that you know, the more that they less they trust their medical teams, the more they wanted to seek information and the more involvement they wanted in decision making. And right the way through to people that said, look, I'll just do whatever the medical team tells me, I'm quite comfortable with that. The less I know, the better. Social support was very important for most people, but that was very much a two-edged sword. Some people were so acutely aware of the burden, the psychological burden they were placing on their family by seeking emotional support from them, because after all, they felt that if the treatment stopped working, it would ultimately be their family that had to deal with that more than themselves, ultimately. They struggled, though, to communicate the seriousness of their illness to those more peripheral members of their social networks, and they started to avoid going to parties and things like that where they'd have to explain to people, because everybody just said, well, you look so well, how can you be seriously ill when your life is perfectly normal? When in fact, these people are living with the possibility that they had less than 6 months to live, and yet there they were, still working, still engaging in all their usual everyday life. And of course, they also formed strong connections with other people who they ran into in the clinic who were having similar treatment for the same disease. And they often felt huge survivor's guilt as one by one, those people that they had got to know had their treatment stopped working. And this one man put it really eloquently, that he couldn't stop thinking particularly of a mother of a patient who died, who was 20 years younger than him. And he thought, well, how unfair must that mother of that young person be feeling, that I'm still going? Felt like really, really random. And this brings us to this sort of appraisal idea of uncertainty. You know, how do you actually make sense of this? And there are two ways in Michelle's model. It's through you compare it with other experiences that are somewhat analogous, or you make use of this idea of illusion, that you leverage the uncertainty to give you a positive worldview. And both of these strategies were really evident in the people we talked to. So as flagged on the previous slide, people very quickly learned it was not advisable to use the frame of reference of other people with MUM, because they learned that everybody was totally unique and different, and there was no rhyme or reason to who would do better or worse. It seemed completely random to them. And they also could not actually base their treatment-related decisions on anything, because there was a knowledge vacuum, and many of them had their oncologists even tell them, look, we have no idea whether this will work for you or not. We're as much in the dark as you are. So many people actually moved away from really investing in taking control of treatment decisions, because they felt actually they had no control over that anyway, based in no knowledge. And they moved into leveraging how they would emotionally cope with all of this through the use of illusion. nearly all of them actually use this uncertainty to exaggerate the possibility that they might be an exceptional responder. So that meant ignoring parts of their illness whenever they could as well. So they would go days in some cases actively trying to avoid thinking about it. But then, of course, they faced a renewed trauma every time that they inevitably had to remember. And it was really interesting the degree to which some people really seem to have fooled themselves genuinely and got trapped into this avoidance, which ultimately was not going to serve them well when the inevitable happened and the treatment stopped working, versus people who were able to maintain this real sense of dissonance. So it's almost like they had half of their brain saying, I'm okay, you know, I just got to get on with life, don't worry about it. And the other half actually actively planning and coping. And this man put it better than everybody. He said, if you trick your body into thinking you're healthy, you stand a better chance. Well, actually, this could be really a load of shit, but it served me well, so I'm going to go with it. That's a really good demonstration of that dissonance thinking. So they mobilized strategies to reduce uncertainty. Some people really needed to have control over some aspect. They couldn't do it in terms of treatment. So they said, well, of treatment decisions. But they said, well, I'm going to make myself as fit as possible. So when the next new treatment comes along, I'll be able to be put on that treatment. And nobody, interestingly, had ever refused treatment. And after all, that's the easiest way to reduce uncertainty, would just be to say, look, I've had enough of this. I'm drawing a line in the sand, no more treatment. And then I know what to expect. Nobody had actually anticipated doing that. Although there were one or two who said, well, if the side effects become too bad, then maybe that would be a situation I'd be willing to take. And that was particularly the older people tended to think in those terms. They managed their emotional response. So first and foremost, that was about staying positive. So exaggerating the likelihood of future breakthroughs, feeling lucky or grateful, even though they had this incredibly rare, dangerous disease. They said, well, look, I've got 5 in a million chance of getting ocular melanoma. What are the odds that I would have qualified for tebentafusp? What are the odds that I'm responding? You know, if you stack up all those uncertainties and those amazing flukes, then you've got to go with the positives and say, well, something else positive might happen as well. Many people derive positive meanings through the change in perspective they've got. They said it put their whole lives in perspective. They found out who their friends were. And this, of course, we found across other cancers and treatments as well. Many people reoriented to just living one day at a time or in the now, simply because they couldn't plan ahead to next year or even the next 6 months. You know, people would say, well, you know, have you got your holiday booked for the end of the year? They'd say, well, I don't even know if I'm going to be here at the end of the year. Incredible uncertainty. And fatalism. So this was a very common strategy, you know, so it's so unlikely that I was diagnosed with this. Well, look, I could even get cured from this disease and then I might get run over by a car the next day, or, you know, everybody's going to die one day. I don't know when it's going to be. You know, this cancer may not make a huge amount of difference to my prognosis anyway. And the good news was that people found this, they got better. It was a skill that they developed over time, using these types of strategies to live with the uncertainty, which was encouraging. Buffering, this is the final part of the uncertainty framework. And this is about actively avoidance. So it's whether it's positive or negative coping strategy is ambivalent, but it's about ignoring information that contradicts that positive behavior. So in the extreme case, there was one woman who would avoid scans. She would actually cancel the scans because until you find out that your cancer spread, it hasn't spread, right? If you think of it from the perspective of somebody living with this disease. They actively were not thinking about treatment failure, and they cordoned off mental space, a couple of them, to advance in financial planning, getting their affairs in order. They would do that for a very brief prescribed period, and then they would just say, okay, I've done that, and then they would move back to this positive coping mechanisms. So in summary and conclusions, it seems that people with MUM exploit 2 opportunities that uncertainty actually offers for hope. These are what philosophers have described as epistemic and aleatoric. So the lack of scientific understanding. We just don't know who's going to respond to these treatments yet. and the randomness and uncontrollability of events more generally. So that's the one about, well, I might get run over by a car anyway. Some people in our sample did seem to maintain hope through denial, and we know from the psychological literature that is associated with poor mental health comes down the track when the treatment stops working and people finally actually have to deal with the reality. And of course, their families often suffer into bereavement, particularly if people only find out very, it's a short period between when they have to face up to the reality and then they die. That's very difficult for the families in bereavement. This kind of idea of hope for the best, but prepare for the worst, walk two paths, as it's been called in palliative care, seems to be really, really pertinent here. And people who are really good at that use this kind of metacognition. They actually are able to trick themselves using this cognitive dissonance. So I think if we're looking to support people who are going through this experience in our clinics, really it's about trying to foster their sense of control, and that is really through their emotional response to this. So they don't have control over whether the treatment works. They don't really even have much control over which treatments they choose, because they are, after all, so limited knowledge about that in the literature. But they do have control over how they effectively emotionally respond to this. And people are likely to need special support around the times of scans, and also maybe some help with talking to those extended social networks. What do I say when people ask me about my illness? But we really need these head-to-head comparisons of these different psychological interventions that have been used for other kinds of treatment. And if you want to read more about this, it has been published in the BMC Cancer Journal. It's open access. Anybody can read it. Thank you very much.
Oh, that was brilliant, Tim. Thanks very much. So we're going to have a discussion now for a few minutes, and we've got there's a question for Vivian in the chat, which is, thank you very much for your fascinating presentation. I'm not sure if you can see it, Vivian, but I'll read it out anyway. So you can see it. So never understood the role of BAP1 before. What's the next stage of your work?
Yep.
Yeah.
So we found out that from the presentation today, the BAP1 deficient cells are surviving better in conditions that are low of amino acids, for example, in the blood circulation. So we're trying to, what we're actively trying to see or study is whether this is true in animal models. So we're going to inject uveal melanoma cells into a mouse and see whether there is more metastasis with BAP1 deficient uveal melanoma. And then we're also looking at the mechanisms that support the survival. We have a few targets that we're trying to validate in the laboratory right now, and whether we can target this mechanism or mechanisms with something that's already in a clinic. And we're also actively looking at the differences in how BAP1 deficient and wild type uveal melanoma cells interact with liver cells. So with liver cells, for example, attract more of BAP1 deficient cells into the liver, more so than BAP1 wild type cells, because of a protein or genetic landscape that's different in BAP1 deficient uveal melanoma cells compared to wild type. So those are the active studies that we are ongoing right now. Thank you.
Brilliant. I mean, this is super fascinating. I've always thought that it'd probably be some intrinsic liver reason why it ends up in the liver, and you're suggesting, in fact, it's the environment in the blood, which is why it ends up in the blood and survives in the blood, and then the liver's the sorting house. Can you talk a bit more about this and particularly, or if it is the blood, so why do you think it ends up in the liver, Vivian?
Why it ends up in the liver?
Yeah.
So we think, based on our data and talking with some of the BAP1 researchers in other cancer types, there are a few proteins that are specifically expressed in BAP1 deficient uveal melanoma compared to wild type. For example, there's this cytokine called CCL2. And potentially there are also other cytokines and growth factor receptors on this BAP1 deficient cells that have ability to be attracted to liver cells more so, and potentially someone or myself will be able to look at that more closely in the future.
Yeah, brilliant. Thanks very much. So Tim, there's a couple of questions in the chat for you as well. I'd like to just ask you, how have you found is there a difference between the other cancer streams or other cancers and the uveal melanoma in terms of these quality of life outcomes? Is there something different that you found specifically for the uveal melanoma patients?
So there has been quite a bit of research on this concept of uncertainty in people living with cancer. But I think, as I said at the beginning, I think MUM really is the ultimate kind of paradigmatic tumor type for studying this phenomenon, particularly where we are in terms of treatment development, because it's so uncertain. You've got the uncertainty of the tumor, it's so rare, you've got the large chance it will metastasize, and then you've got this limited range of treatments and then new treatments. So we're not yet at the end of people who were the first to receive these new generation treatments. So we actually have no idea at the very end of the limits of how well people can do. So you put all those things together, and it is difficult to think of any treatment context right now that has associated with more uncertainty.
Mm. Okay, yeah, brilliant. So the uncertainty, yeah, absolutely. There's a couple of questions here for you as well. So Tim, can you explain a bit more about how the data for the qualitative study was collected? And then this is also, I'd love to hear about, how do you think, you mentioned it a bit in your conclusions, how you think the research can be translated to clinical care, particularly about help around the time of scans. But if you could comment on those couple of things, that'd be great.
Yeah, so I guess it's for very quantitative-minded researchers in the audience, it may be worth explaining just a little bit about how qualitative research works, and particularly around the sample size. So 17 people may not sound very big, but that enabled us to get to a point of what we refer to in qualitative research as saturation, which means that actually we were just hearing the same thing from each new participant that we interviewed, which is where, so in other words, you reach a point where really you feel like you've covered the major issues for people that you talk to. And you can intentionally, purposefully sample. So you choose people who are likely to have had a different experience from the people that you've already interviewed. So maybe have been on a different kind of treatment, or they're at a different stage in their journey through treatment. And you see whether the theory that you've built over the first few interviews actually can be tested and stands up in those subsequent interviews. And we found that it did. So even though it's a small sample, it's amazing actually how people's experience and their perspectives on that can actually be fundamentally very similar. Of course, people have different life circumstances, different family situations, so there are certainly lots of differences. But at the crux, in terms of these sorts of coping mechanisms, it seemed to be the way people go. So what that means in terms of translating into clinical practice is, I think it gives you a pretty good idea of the types of positive and less positive coping strategies people may be using who are your patients, and how you can help them through that. At a basic level, it could inform, for example, patient education materials, supportive care interventions, could inform video materials that show to people. A lot of people, for example, talked about how when they began treatment, they were really keen to meet other people with MUM because they felt that was a peer network who would give them a lot of support. Most people, not all of them, and we had a couple of people who actually ran social media networks for people with MUM, so they were exceptions. But most people actually found that not helpful. Even though initially they sought people out, they found that seeing people get sicker and sicker, come off treatment and die, actually really undermined their own coping strategy. So that's a little example of something that people might feel they really want to try in the early days, and the clinician could just give them a little bit of warning about that up fine. I mean, if you want to do that, by all means, but just remember the treatment pathway it's going to be very, very different for each individual person, and don't try to generalize from another patient you meet in the waiting room to your own situation, because the chances are it will be very different.
Yeah, thanks for that explanation. That's really useful. Anthony has asked a question, I think for Vivian. Any possibility for synthetic lethality or activation lethality given those findings? Not sure exactly which findings, but maybe you are, Vivian.
There's possibility. So for example, with the survival under amino acid starvation, we have a list of proteins that were at a higher level following amino acid starvation, and some at a lower level or decreased in expression compared to in regular media. And so we are currently trying to validate those targets right now, and potentially we could knock out or knock down those targets that are elevated, and then we could also maybe activate or overexpress some of those targets that are downregulated to see if they would respond better to amino acid starvation.
I mean, you're setting up a lab here in Australia. You've worked overseas. How are you finding the Australian environment with research support and funding as compared to overseas?
Yeah, so I'm still learning. So it's very different. And currently I am in the process of trying to connect with clinicians, which is quite difficult because compared to when I was at Jefferson, so Takami Sato is someone who sees about 20 to 30% of metastatic uveal melanoma patients in the country, in the United States. And so he's just across the road from our lab. And so we see him maybe once a week. And so that was something that I hope to build the connection with within Western Australia. Yeah.
Yeah, fantastic. Well, you can do that, Victoria. We meet every month.
Nice. Yep. Yeah. Hope to visit one day.
Yeah. Anyway, and Tim, I suppose the other thing that I was wondering, so the validated quality of life tool that we have available for uveal melanoma is now 30 years old, or a bit over 30 years old, the EORTC one, and it's currently being redone. How do you see a role for those types of tools in clinical practice? Is this a thing that we could use to identify patients that are having trouble, or how can we use them?
Yeah, good question. And I've just posted in the chat that I think some clinicians will be surprised that actually uncertainty was flagged as far and away the most difficult, challenging issue for everybody in our study. So we did ask about quality of life more generally, side effects, burdens of treatment, having to, travel long distances, or spend time in hospital when you're starting these immunotherapies, etc. All of that people took in their stride compared to this living with uncertainty. And that's not an issue that's well covered by these quality of life tools. I guess really because maybe many clinicians don't offer a whole lot of supportive care for that more psychosocial concern type of thing, unless you're somewhere like Peter Mac, that's the Centre of Excellence for Psycho-Oncology. Not every clinic has those types of services available. And of course, there's always this sort of challenge, do you want to identify problems that you're not actually going to be able to address? In terms of the other quality of life issues, I think most of those we found were reasonably well covered by existing questionnaires, not only the one you mentioned, but for example, there is a FACT immunotherapy questionnaire that does a very good job of all the skin symptoms and all of those sorts of things. So I think with the exception of the uncertainty issue, I think most of the issues that people raise actually are quite well covered, not by one questionnaire, but by sort of pulling together different scales from different questionnaires. And we have another paper we've published where we give some advice on that, if people are interested in that, with the same authorship team. Yeah, I think it's this uncertainty, and we are hoping to develop a questionnaire that deals with it, addresses this uncertainty, but that will go beyond MUM. I think that's a generic issue for people facing similar sorts of treatment contexts. And from a methodological perspective, it's actually very difficult to develop and validate a questionnaire in MUM because it's such a rare cancer. It's very difficult to get a big enough sample size to, give you the statistical power you need for that.
Oh, this has been fascinating listening and learning from you guys. Thank you very much. And Tim, it is every time I see patients, uncertainty seems to be the thing that keeps coming up. Yeah, it is on the ground. That's what we hear. So the next session starts shortly. Thanks very much, guys.